Systemic lupus erythematosus, SLE, is a complex autoimmune disease with symptoms that can mimic many other conditions. Its wide range of manifestations, affecting the skin, joints, kidneys, heart, lungs, and nervous system, often leads to misdiagnosis. Here are some conditions that commonly mimic SLE. 1. Rheumatoid arthritis, RA. Both SLE and RA cause joint pain, swelling, and stiffness, making it challenging to distinguish between them, especially in the early stages. 2. Fibromyalgia, fatigue, diffuse pain, and cognitive symptoms seen in fibromyalgia can overlap with those of SLE. 3. Sjogren's syndrome. Overlapping symptoms such as dry eyes, dry mouth, fatigue, and joint pain can confuse the diagnosis with SLE. 4. Mixed connective tissue disease, MCTD. This condition has features of lupus, scleroderma, and polymyositis, creating diagnostic uncertainty. 5. Vasculitis. Both conditions involve blood vessel inflammation, leading to similar presentations such as skin rashes, renal involvement, and neurological symptoms. 6. Dermatomyositis. The rash and muscle weakness in dermatomyositis can mimic the skin and muscle symptoms of SLE. 7. Infectious diseases. Chronic infections like viral hepatitis, tuberculosis, and HIV can present with fatigue, fever, and systemic symptoms resembling SLE. 8. Drug-induced lupus. Certain medications such as hydralazine, procainamide, and isoniazid can cause a lupus-like syndrome that is indistinguishable from SLE until the offending drug is discontinued. 9. Antiphospholipid syndrome, APS. Though often associated with SLE, APS can occur on its own and can mimic lupus with symptoms like blood clots, miscarriage, and skin rashes. 10. Multiple sclerosis, MS. Neurological involvement in SLE can resemble MS, especially when there is brain or spinal cord involvement. 11. Scleroderma. Skin tightening and organ involvement in scleroderma can be mistaken for SLE, particularly when both are part of overlap syndromes. Given SLE's systemic nature, thorough clinical evaluation, laboratory testing, and sometimes biopsies are necessary to accurately differentiate these conditions. There are several rare syndromes that can mimic systemic lupus erythematosus, SLE, due to their overlapping symptoms, making diagnosis challenging. Some of these rare conditions include 1. Antisynthetase syndrome. This rare autoimmune disease involves interstitial lung disease, myositis, arthritis, and skin changes, which can resemble the joint and lung manifestations of SLE. 2. Adult onset Still's disease, AOSD. This autoinflammatory condition presents with high fevers, rash, and joint pain, which can closely mimic the systemic features of SLE, especially in patients with recurrent fevers. 3. Cryoglobulinemia. This condition can cause vasculitis, kidney involvement, and skin rashes similar to those seen in lupus. It is often associated with infections like hepatitis C. 4. Sweet syndrome, acute febrile neutrophilic dermatosis. This rare skin condition presents with painful skin lesions, fever, and elevated white blood cell counts, which can resemble the rash and systemic inflammation seen in SLE. 5. Relapsing polychondritis. This inflammatory disease affects cartilage, especially in the ears, nose, and airways. It can be confused with lupus when systemic symptoms like fever, arthritis, and rash occur. 6. Undifferentiated connective tissue disease, UCTD. This condition shares features with lupus, but does not meet the full criteria for any specific autoimmune disease, creating diagnostic ambiguity. 7. Whipple's disease, a rare bacterial infection that can present with arthritis, weight loss, diarrhea, and neurological symptoms, overlapping with the systemic features of SLE. 8. Immunoglobulin G4-related disease, IgG4-RD. This systemic disease can affect multiple organs, causing inflammation, mimicking SLE with manifestations such as kidney involvement, salivary gland swelling, and autoimmune-like features. 9. Hereditary angioedema, HA. While typically involving sudden, recurrent swelling, HAE can also cause abdominal pain, rash, and fatigue, sometimes leading to confusion with lupus in the early stages. 10. Autoimmune lymphoproliferative syndrome, ALPS. A genetic disorder that affects lymphocyte regulation and can cause symptoms similar to SLE, including autoimmune cytopenias, enlarged lymph nodes, and splenomegaly. 11. Familial Mediterranean fever, FMF. This autoinflammatory disorder presents with periodic fevers, serositis, and arthritis, mimicking the systemic inflammatory features of lupus. 12. Hemophagocytic lymphohistiocytosis, HLH. a life-threatening immune response syndrome that can cause fever, cytopenias, liver dysfunction, and other systemic symptoms resembling lupus. Each of these rare syndromes requires careful clinical evaluation, laboratory testing, and sometimes genetic or biopsy confirmation to distinguish from lupus. Misdiagnosis can occur due to the broad overlap in systemic symptoms like rash, arthritis, fever, and organ involvement. Lupus nephritis, LN, is a serious complication of systemic lupus erythematosus, SLE, that involves inflammation of the kidneys. Because of its varied presentation, lupus nephritis can be mistaken for other renal diseases. Here are some conditions that can mimic lupus nephritis. 1. IgA nephropathy, Berger's disease. Overlap. Both conditions can present with hematuria, blood in the urine, and proteinuria, protein in the urine. Kidney biopsy may be needed to differentiate them. Difference. IgA nephropathy often occurs after an upper respiratory or gastrointestinal infection, which may not be the case in lupus nephritis. 2. Membranous nephropathy. Overlap. Both lupus nephritis and membranous nephropathy can cause heavy proteinuria and nephrotic syndrome, swelling, low albumin levels, high cholesterol. Difference. Lupus nephritis is usually associated with systemic symptoms like rash, arthritis, and positive lupus serologies, whereas membranous nephropathy typically lacks these systemic features. 3. ANCA-associated vasculitis, AAV. Overlap. Both conditions can cause rapidly progressive glomerulonephritis with kidney failure, hematuria, and proteinuria. Difference. ANCA-associated vasculitis usually has positive ANC antibodies and lacks the immune complex deposits seen in lupus nephritis biopsies. 4. Post-infectious glomerulonephritis, PEN. Overlap. Both can present with hematuria, proteinuria, and edema after an infection. Difference. PN usually follows an obvious infection, e.g., streptococcal throat infection, whereas lupus nephritis may not have a clear infectious trigger and is often associated with positive lupus serologies. 5. Goodpasture's syndrome, anti-GBM disease. Overlap. Both can cause rapidly progressive kidney failure with hematuria. Difference. Goodpasture syndrome typically involves the lungs, pulmonary hemorrhage, and is characterized by antiglomerular basement membrane, GBM antibodies, which are absent in lupus nephritis. 6. Thrombotic microangiopathy, TMA. Overlap. TMA can occur in lupus patients, making it difficult to distinguish from lupus nephritis. Both conditions can cause renal failure, hematuria, and thrombocytopenia, low platelets. Difference. TMA is associated with microangiopathic hemolytic anemia and schistocytes, fragmented red blood cells, on a blood smear, which may not be prominent in lupus nephritis. Number 7. Focal segmental glomerulosclerosis, FSGS. Overlap. FSGS can cause heavy proteinuria and nephrotic syndrome, similar to certain classes of lupus nephritis. Difference. FSGS typically lacks the immune complex deposits found in lupus nephritis and is confirmed via kidney biopsy. 8. Diabetic nephropathy. Overlap. Both conditions can cause proteinuria, kidney dysfunction, and sometimes nephrotic syndrome. Difference? Diabetic nephropathy usually occurs in the setting of long-standing diabetes, with characteristic diabetic retinopathy and other vascular complications. 9. Henoch-Schönlein purpura, HSP. Overlap. This small vessel vasculitis shares some features with lupus nephritis, including hematuria, proteinuria, and skin rash. Difference. HSP primarily affects children and often presents with abdominal pain and purpura, and it is usually self-limited, unlike lupus nephritis. 10. Scleroderma renal crisis. Overlap. Both conditions can cause hypertension, kidney failure, and proteinuria. Difference. Scleroderma renal crisis is characterized by a sudden onset of severe hypertension, usually in patients with scleroderma, and lacks the immune complex deposits seen in lupus nephritis. 11. Primary glomerulonephritis. Overlap. Many forms of primary glomerulonephritis, e.g., minimal change disease, membranoproliferative GN, can mimic lupus nephritis with proteinuria, hematuria, and kidney dysfunction. Difference. Unlike lupus nephritis, primary GN lacks systemic lupus features such as positive ANA or dsDNA antibodies and immune complex deposits typical of lupus nephritis. Diagnostic considerations. Kidney biopsy. essential for distinguishing lupus nephritis from many mimics, as it can reveal immune complex deposits and specific histological patterns. Autoimmune serologies, positive antinuclear antibodies, ANA, anti-double-stranded DNA, dsDNA, and low complement levels, C3, C4, strongly suggest lupus nephritis. Systemic symptoms. The presence of systemic lupus features like arthritis, skin rash, and pleuritis helps differentiate lupus nephritis from other renal diseases. Accurate diagnosis is crucial, as treatment for lupus nephritis, e.g., immunosuppression, differs significantly from many of its mimics. Neuropsychiatric lupus, NPSLE, is a challenging manifestation of systemic lupus erythematosus, SLE, involving the central and peripheral nervous systems. Its symptoms can mimic a wide range of neurological and psychiatric disorders, making diagnosis complex. Below are some conditions that can mimic neuropsychiatric lupus. 1. Multiple sclerosis, MS. Overlap. Both MS and NPSLE can present with optic neuritis, cognitive dysfunction, fatigue, and motor or sensory deficits. Difference. MS typically shows specific brain and spinal cord lesions on MRI, e.g. paraventricular plaques, and has a distinct pattern of oligoclonal bands in cerebrospinal fluid, CSF. 2. Central nervous system, CNS vasculitis. Overlap. CNS vasculitis can cause stroke, seizures, headaches, and cognitive decline, similar to NPSLE. Difference. CNS vasculitis may not have systemic lupus features, like rash or arthritis, and biopsy or angiography may be needed to confirm small or medium vessel inflammation. 3. Stroke or transient ischemic attack. Overlap. NPSLE can cause cerebrovascular disease, leading to stroke-like symptoms such as sudden weakness, slurred speech, and vision changes. Difference. TIAs or strokes in non-lupus patients are typically related to atherosclerosis, hypertension, or embolism, while lupus-associated strokes often occur in younger patients and may be associated with antiphospholipid syndrome, APS. 4. Antiphospholipid syndrome, APS. Overlap. APS can cause similar neuropsychiatric manifestations, including stroke, cognitive dysfunction, and psychiatric symptoms. Difference. APS is often associated with recurrent thrombosis, blood clots, and pregnancy complications, and may occur independently of lupus. Positive antiphospholipid antibodies, APL, are key to distinguishing APS from NPSLE. 5. Migraine and other headache syndromes. Overlap. Both NPSLE and migraine can present with severe, recurrent headaches, visual disturbances, and even transient neurological symptoms. Difference. Lupus-associated headaches may be more persistent and resistant to typical migraine treatments, and they are often associated with other systemic lupus symptoms. 6. Overlap. Seizures are a well-known feature of NPSLE, mimicking primary epilepsy. Difference. Seizures in lupus are often accompanied by other systemic lupus signs and may be related to vasculitis, infection, or inflammation of the brain. 7. Psychiatric disorders, e.g. depression, anxiety, psychosis. Overlap. NPSLE can cause mood changes, depression, anxiety, and even psychosis, which can mimic primary psychiatric conditions. The psychiatric symptoms in NPSLE are often associated with systemic inflammation. Other neuropsychiatric symptoms, e.g. cognitive dysfunction or abnormal CSF findings, and may improve with immunosuppressive therapy. 8. Dementia, Alzheimer's disease, or vascular dementia. Overlap. Cognitive dysfunction is common in NPSLE, leading to memory loss, confusion, and difficulty concentrating, similar to dementia. Difference. In NPSLE, cognitive issues often fluctuate and are reversible with appropriate treatment, whereas Alzheimer's disease typically progresses steadily over time. 9. Infections of the CNS, e.g. meningitis, encephalitis. Overlap. CNS infections can cause fever, headache, confusion, seizures, and altered mental status, mimicking NPSLE. Difference. Infections often present with fever and more pronounced inflammatory markers in CSF, e.g. neutrophilic pleocytosis, elevated protein. Imaging and cultures help distinguish infectious causes. 10. Functional neurological disorders, FND. Overlap. Functional neurological symptoms like pseudoseizures, weakness, and sensory disturbances can resemble those of NPSLE. Difference. FND symptoms typically lack the objective neurological findings seen in NPSLE, e.g. abnormal MRI or CSF, and psychological stressors often play a role. 11. Hypertensive encephalopathy. Overlap. Both conditions can cause confusion, seizures, and headaches due to acute blood pressure elevation. Difference. Hypertensive encephalopathy is related to sudden severe hypertension and typically improves with blood pressure control, while NPSLE may involve more complex immune-mediated mechanisms. 12. Sarcoidosis, overlap. Neurosarcoidosis can mimic NPSLE by causing cranial nerve palsies, cognitive dysfunction, headaches, and seizures. Difference. Sarcoidosis is often distinguished by granulomas on biopsy and elevated angiotensin-converting enzyme, ACE levels, and it may affect other organs like the lungs more predominantly than lupus. 13. Lyme disease. Overlap. Neuroborreliosis, a neurological manifestation of Lyme disease, can present with cognitive impairment, headaches, and neuropathy, resembling NPSLE. Difference. Lyme disease typically presents with a history of tick bite or erythema migrans rash, and Lyme serologies and CSF analysis can help differentiate it. 14. Systemic inflammatory diseases, e.g. Behçet's disease, Sjogren's syndrome. Overlap. Both Behçet's disease and Sjogren's syndrome can cause neurological involvement, e.g. stroke, cognitive dysfunction, psychiatric symptoms, similar to NPSLE. Difference. Behçet's disease often presents with oral and genital ulcers and a different pattern of vasculitis, while Sjogren's syndrome is associated with Zika symptoms, dry eyes, dry mouth, and anti-Ro SSA antibodies. HAR15. Progressive multifocal leukoencephalopathy. Overlap. PML. A rare but serious brain infection seen in immunocompromised individuals, e.g. lupus patients on immunosuppressive therapy, can cause progressive cognitive decline, seizures, and motor deficits, resembling NPSLE. Difference. PML is caused by the JC virus and is confirmed by MRI showing demyelinating lesions and positive JC virus DNA in CSF. Diagnostic tools to differentiate. MRI and CT scans to assess structural abnormalities, white matter lesions, or vasculitis. Cerebrospinal fluid, CSF analysis, helpful in identifying infection, inflammation, and specific markers like oligoclonal bands, MS, or elevated protein in cells, infection, vasculitis. Used to differentiate between true seizures and pseudoseizures, as well as to assess abnormal brain activity in NPSLE. Serology, positive ANA, anti-dsDNA, and antiphospholipid antibodies can help support a diagnosis of NPSLE over other conditions. Neuropsychological testing, used to assess cognitive function and differentiate lupus-related cognitive dysfunction from dementia or other neurodegenerative disorders. Accurate diagnosis of NPSLE requires careful clinical evaluation, detailed imaging, and laboratory testing to exclude these mimicking conditions. Malar rash, the characteristic butterfly rash, and other skin manifestations of lupus can be mimicked by various conditions. Because the rash is often photosensitive and appears on the face, distinguishing lupus-related skin lesions from other dermatological conditions can be challenging. Below are some common and rare mimics of malar rash and other lupus skin manifestations. Mimics of malar rash. 1. Rosacea. Overlap. Both conditions can present with redness and inflammation on the cheeks and nose. Difference. Rosacea tends to involve papules and pustules, acne-like lesions, and spares the nasolabial folds, which are often affected in lupus. Rosacea also lacks systemic symptoms and is not associated with autoantibodies.
This is wrong. The nasolabial fold is also not affected in the systemic lupus.
Both conditions can present with redness and scaling on the face. Difference. Seborrheic dermatitis typically affects areas rich in sebaceous glands, such as the nasolabial folds, eyebrows, and scalp. It presents with greasy scales, unlike the dry erythematous rash of lupus. 3. Dermatomyositis. Overlap. Dermatomyositis can present with a malar-like rash, heliotrope rash on the face and around the eyes, along with systemic involvement such as muscle weakness. Difference. Dermatomyositis is often associated with a violaceous hue around the eyes, heliotrope sign, and Gottron's papules over the knuckles, which are absent in lupus. Muscle weakness and elevated muscle enzymes are key features. 4. Polymorphous light eruption, PMLE. Overlap. Both conditions are photosensitive and cause rashes after sun exposure. Difference. PMLE usually presents with small papules, vesicles, or plaques on sun-exposed areas, but typically lacks the systemic features of lupus. It also tends to affect the arms, neck, and chest, not just the face. 5. Erysipelas. Bacterial skin infection. Overlap. Erysipelas can present with sharply demarcated, red, and swollen areas of skin, especially on the face. Difference. Erysipelas is usually caused by a bacterial infection, often streptococcus, leading to more warmth, swelling, and tenderness. It is typically associated with fever and requires antibiotic treatment. 6. Contact dermatitis. Overlap. Contact dermatitis can present with a red, itchy, and sometimes blistering rash on the face, resembling a lupus rash. Difference. Contact dermatitis often has a clear trigger, e.g. cosmetics or topical irritants, and is usually localized to the area of exposure. It may be more pruritic, itchy, than a lupus malar rash. 7. Atopic dermatitis, eczema. Overlap. Both conditions can cause redness, scaling, and irritation on the face. Difference. Atopic dermatitis is usually more pruritic, itchy, and occurs in areas like the cheeks, but also behind the knees, in the elbow creases, and on the hands. It is often associated with a history of allergies or asthma. Mimics of discoid lupus erythematosus, DLE. 1. Psoriasis. Overlap. Both conditions can present with scaly, erythematous plaques on the skin, particularly on the scalp and face. Difference. Psoriasis plaques are usually thicker and have silvery scales. Psoriasis also commonly affects the extensor surfaces of the elbows and knees, whereas discoid lupus lesions are more common on the face and scalp and may lead to scarring. 2. Lichen planus. Overlap. Lichen planus can present with flat-topped, violaceous, itchy papules or plaques that may be mistaken for discoid lupus lesions. Difference. Lichen planus lesions are often polygonal and purplish, typically appearing on the wrists, ankles, and oral mucosa. They lack the scarring and hypopigmentation typical of discoid lupus. 3. Tinea facie, fungal infection. Overlap. Tinea facie can present with red, scaly patches on the face, which can mimic the appearance of discoid lupus. Difference. Tinea often has a more defined ring-like border, hence ringworm, and is usually diagnosed by a KOH, potassium hydroxide test, revealing fungal hyphae. Mimics of subacute cutaneous lupus erythematosus, SLE. 1. Pityriasis rosea. Overlap. Both conditions can present with scaly erythematous plaques on sun-exposed areas, resembling the annular or papulosquamous lesions seen in SLE. Difference. Pityriasis rosea often starts with a herald patch, followed by smaller lesions in a Christmas tree pattern on the trunk. It is usually self-limited and lacks systemic symptoms. Drug eruptions, photosensitive. Overlap. Some medications can cause photosensitive eruptions that mimic SLE, especially drugs like thiazides, tetracyclines, or NSAIDs. Difference. Drug eruptions typically improve after discontinuation of the offending drug and lack other lupus features, such as positive ANA or systemic involvement. 3. Erythema multiforme. Overlap. Both conditions can present with erythematous plaques on the skin. Difference. Erythema multiforme is often caused by infections, e.g. herpes simplex, or drugs, and is characterized by target lesions with a central dusky area, which are not seen in lupus. It may also affect the mucous membranes. Mimics of acute cutaneous lupus. 1. Viral exanthems, e.g. parvovirus B19, measles. Overlap. Viral rashes can present with widespread erythematous and maculopapular lesions, which may be confused with the acute cutaneous lupus rash. Difference. Viral exanthems are often associated with fever, malaise, and a history of recent infection. The rash typically resolves as the viral infection subsides and does not recur with sun exposure like lupus rashes. 2. Erythema nodosum. Overlap. Erythema nodosum presents with red, tender nodules, which can occur alongside systemic symptoms like fever or fatigue, similar to lupus. Difference. Erythema nodosum typically affects the lower legs and presents with deeper nodules rather than superficial plaques or rashes. Diagnostic considerations. Biopsy. Skin biopsies in lupus typically show interface dermatitis with vacuolar degeneration of the basal layer, which can help differentiate lupus from mimics like rosacea or seborrheic dermatitis. Autoimmune serologies, positive ANA, anti-dsDNA, anti-SM, or anti-Rho SSA antibodies support a lupus diagnosis, while their absence may suggest a different etiology. Photosensitivity. Lupus rashes tend to worsen with sun exposure, while many mimicking conditions, e.g., rosacea, contact dermatitis, may not have the same degree of photosensitivity. Lupus related skin conditions can be varied and resemble numerous dermatologic diseases, necessitating a comprehensive approach to diagnosis, including clinical history, skin biopsy, and serological tests. The musculoskeletal manifestations of systemic lupus erythematosus, SLE, include a wide range of symptoms such as joint pain, arthralgia, joint inflammation, arthritis, muscle pain, myalgia, and occasionally muscle weakness. These symptoms can mimic other conditions, making diagnosis challenging. Here are some conditions that mimic the musculoskeletal manifestations of SLE. Mimics of SLE arthritis and arthralgia. 1. Rheumatoid arthritis overlap. Both SLE and RA can present with symmetric joint pain, swelling, and morning stiffness, especially in the small joints of the hands and wrists. Difference. RA typically causes more aggressive joint erosion visible on X-ray, and the involvement is often more severe with deformities like ulnar deviation and swan neck deformities. RA is associated with rheumatoid factor, RF, and anti-citrullinated peptide antibodies, ACPA, which are generally absent in lupus. 2. Osteoarthritis, OA, overlap. Both conditions can cause joint pain and stiffness, particularly in the hands, knees, and hips. Difference. OA pain tends to worsen with activity and improve with rest, and it lacks systemic features like fever, rash, or fatigue. OA often affects the larger weight-bearing joints and causes bone spurs or joint space narrowing on X-rays, which are uncommon in lupus arthritis. 3. Fibromyalgia. Overlap. Both lupus and fibromyalgia can cause widespread musculoskeletal pain, fatigue, and sleep disturbances. Difference. Fibromyalgia is characterized by tender points, lacks the inflammatory component, such as joint swelling or elevated inflammatory markers, and is not associated with serological markers like ANA or anti-dsDNA. Lupus may also have objective findings of inflammation, such as elevated ESR or CRP, which are normal in fibromyalgia. 4. Polymyalgia rheumatica. Overlap. Both conditions can cause morning stiffness and muscle pain, especially in the shoulder and hip girdle. Difference. PMR usually occurs in older adults, over 50 years old, and responds rapidly to low-dose corticosteroids. It is also associated with elevated ESR, but lacks other lupus symptoms such as rash, oral ulcers, or renal involvement. 5. Psoriatic arthritis, A. Overlap. PSA can mimic lupus with joint pain, swelling, and stiffness, sometimes involving the hands and feet. Difference. PSA is often associated with psoriasis, scaly skin lesions, and characteristic nail changes, e.g. pitting, onycholysis. PSA can also cause more asymmetrical joint involvement and may affect the spine, spondyloarthropathy, unlike the typical lupus arthritis. X-rays in PSA show characteristic bone changes, e.g. pencil and cup deformity, which are not seen in lupus. 6. Reactive arthritis. Overlap. Both conditions can present with arthritis in multiple joints, particularly in younger individuals, along with systemic symptoms like fever and malaise. Difference. Reactive arthritis often follows an infection, e.g. gastrointestinal or genitourinary, and is associated with features like conjunctivitis and urethritis, Reiters, which are not typical of lupus. Joint involvement in reactive arthritis is often more asymmetric. 7. Gout. Overlap. Both conditions can cause acute joint pain, swelling, and redness, commonly affecting the lower extremities, e.g. knees, ankles. Difference. Gout typically presents as an acute attack with sudden onset of severe pain, most often affecting the big toe, podagra. It is characterized by elevated serum uric acid and urate crystals found in joint fluid analysis, which are absent in lupus. 8. Sjogren's syndrome. Overlap. Sjogren's syndrome, like lupus, can cause joint pain, swelling, and fatigue. Difference. Sjogren's syndrome is primarily characterized by sicca symptoms, dry eyes, dry mouth, and though it can overlap with lupus, it usually has more prominent glandular involvement. Anti-Ro SSA and anti-LA SSB antibodies are more characteristic of Sjogren's, whereas lupus typically has anti-dsDNA and anti-Smith antibodies. Mimics of SLE myalgia and myositis. 1. Polymyositis and dermatomyositis. Overlap. Both polymyositis and dermatomyositis can present with muscle weakness, particularly in the proximal muscles, shoulders, and hips, and may involve skin rashes in dermatomyositis mimicking lupus. Difference. Polymyositis and dermatomyositis often cause more pronounced muscle weakness, elevated muscle enzymes, creatine kinase aldolase, and characteristic rashes, such as Gottron's papules, dermatomyositis. Lupus myositis tends to be milder and is often accompanied by other lupus-specific systemic symptoms. 2. Hypothyroidism, overlap. Both hypothyroidism and lupus can cause muscle pain and weakness, along with fatigue and joint aches. Difference. Hypothyroidism is often associated with other symptoms like weight gain, cold intolerance, constipation, and dry skin. TSH and thyroid hormone levels help distinguish hypothyroidism from lupus. 3. Statin-induced myopathy. Overlap. Statin medications can cause muscle pain and weakness similar to lupus myositis. Difference. Statin-induced myopathy is related to the use of statins, cholesterol-lowering medications, and typically improves upon discontinuation of the drug. Lupus myositis is more likely to present with systemic lupus symptoms and elevated ANA or anti-dsDNA antibodies. 4. Inclusion body myositis. Overlap. Both inclusion body myositis and lupus can cause muscle weakness and inflammation. Difference. Inclusion body myositis primarily affects older individuals and has a more insidious onset, with involvement of both proximal and distal muscles, including finger flexors, which is uncommon in lupus. Muscle biopsy reveals inclusion bodies, which are not seen in lupus myositis. 5. Viral myositis. Overlap. Viral infections, especially those caused by influenza or Coxsackie viruses, can cause acute muscle pain and inflammation, mimicking lupus myositis. Difference. Viral myositis is often self-limited and resolves as the infection subsides. It may be accompanied by fever and other symptoms of a viral infection, and muscle enzymes may be temporarily elevated, but normalize once the infection clears. Mimics of SLE bone pain. 1. Osteonecrosis, a vascular necrosis, overlap. Osteonecrosis, especially in lupus patients treated with corticosteroids, can cause joint pain, particularly in the hips and knees. Difference. Osteonecrosis pain is usually more localized and is related to bone death due to reduced blood supply. MRI can confirm the diagnosis by showing characteristic changes in the affected bones, which are not seen in lupus arthritis. 2. Osteoporosis and fractures. Overlap. Both conditions can cause bone pain and are more common in lupus patients, especially those on long-term corticosteroids. Difference. Osteoporosis pain is often diffuse and related to bone fragility, whereas lupus arthritis causes joint pain with inflammatory features. X-rays or bone density scans can confirm osteoporosis. 3. Bone infection, osteomyelitis. Overlap. Both lupus and bone infections can cause bone pain and systemic symptoms like fever. Difference. Osteomyelitis is usually associated with localized warmth, swelling, and redness, and often follows trauma or surgery. Blood cultures and imaging, e.g. MRI, can help distinguish it from lupus-related bone pain. Diagnostic considerations. Imaging. X-rays, MRI, and ultrasound can help differentiate erosive arthritis, RA, a vascular necrosis, and other structural abnormalities from lupus arthritis, which typically spares the bones. Serological tests, positive ANA, anti-dsDNA, and other lupus-specific antibodies support lupus, while antibodies like RF and ACPA are more suggestive of RA. Joint fluid analysis, useful for distinguishing between lupus arthritis and gout, infections, or other inflammatory conditions by analyzing white blood cell count, crystals, and culture results. Muscle enzymes. Elevated creatine kinase, CK, and aldolase point towards myositis, polymyositis, dermatomyositis, rather than lupus myalgia, which may have normal or mildly elevated levels. These mimics can overlap significantly with SLE, making it essential to conduct a thorough history, physical examination, and appropriate diagnostic testing to reach the correct diagnosis. Systemic lupus erythematosus, SLE, has a wide range of systemic manifestations affecting almost every organ system. Apart from the renal, neuropsychiatric, mucocutaneous, and musculoskeletal manifestations, other organ systems, such as cardiovascular, pulmonary, gastrointestinal, and hematological, can also be involved. Here are some conditions that can mimic non-renal, non-neuropsychiatric, non-mucocutaneous, and non-musculoskeletal manifestations of SLE. 1. Cardiovascular manifestations mimics. A. Pericarditis and myocarditis. Mimics. 1. Viral pericarditis or myocarditis. Viral infections, e.g., Coxsackie virus, enteroviruses, often present with pericardial or myocardial inflammation similar to lupus. Viral pericarditis is often acute, associated with fever, and may not have associated autoimmune markers. 2. Rheumatic heart disease. Post-streptococcal autoimmune heart disease can mimic lupus with pericarditis and valvular involvement. 3. Dressler's syndrome. This post-myocardial infarction syndrome can cause pleuritic chest pain and pericarditis, mimicking lupus. B. Valvular heart disease. Liebman-Sachs endocarditis, mimics. 1. Infective endocarditis. This condition can present with valvular vegetations and systemic symptoms like fever, mimicking Liebman-Sachs endocarditis. Blood cultures, echocardiography, and serologies help differentiate it from lupus-related endocarditis. 2. Non-bacterial thrombotic endocarditis, NBTE, seen in hypercoagulable states, e.g. malignancy. This can present similarly to lupus endocarditis, with sterile vegetations on the heart valves. C. Raynaud's phenomenon, mimics. 1. Scleroderma. Like SLE, scleroderma often causes Raynaud's phenomenon, but it is more commonly associated with skin thickening and tightening, especially around the fingers and face. 2. Primary Raynaud's disease. In patients without systemic involvement, Raynaud's may occur without any underlying autoimmune disease and lacks the systemic symptoms or organ involvement seen in lupus. 3. Vasculitis, e.g. cryoglobulinemia. Other autoimmune conditions or infections can cause Raynaud's phenomenon with systemic vasculitis symptoms. 2. Pulmonary manifestations mimics. A. Pleuritis, mimics. 1. Viral or bacterial pleuritis. Infections can cause pleuritic chest pain, fever, and pleural effusions, mimicking lupus pleuritis. 2. Pulmonary embolism. Sudden onset pleuritic chest pain, shortness of breath, and tachycardia can mimic lupus pleuritis, but may be related to thromboembolic disease, especially in lupus patients with antiphospholipid syndrome, APS. 3. Tuberculosis, TB. Pleural effusion. TB can cause chronic pleuritis and pleural effusions, often confused with lupus pleuritis, especially in endemic areas. B. Lupus pneumonitis and pulmonary hemorrhage. Mimics. 1. Infectious pneumonia. Bacterial, viral, or fungal pneumonia can mimic lupus pneumonitis with symptoms of cough, fever, and dyspnea, but often has positive cultures or imaging features more suggestive of infection. 2. Pulmonary vasculitis, e.g., granulomatosis with polyangiitis. Pulmonary vasculitis can cause hemoptysis, dyspnea, and alveolar hemorrhage, mimicking lupus-associated pulmonary hemorrhage. C-ANCA testing can differentiate granulomatosis with polyangiitis from lupus. 3. Acute respiratory distress syndrome, ARDS. Severe pulmonary involvement from various causes can lead to ARDS, presenting similarly to lupus pneumonitis. 3. Gastrointestinal and hepatic manifestations, mimics. A. Abdominal pain and lupus peritonitis, mimics. 1. Appendicitis or cholecystitis. Acute abdominal pain due to inflammation of the appendix or gallbladder can mimic lupus peritonitis, but surgical imaging and lab results may reveal the source of infection. 2. Pancreatitis. Lupus can cause pancreatitis, but this condition may also be drug-induced from lupus medications like corticosteroids or azathioprine, or due to gallstones or alcohol use. 3. Irritable bowel syndrome, IBS. Chronic abdominal pain in lupus patients can sometimes resemble IBS, but lupus may present with more systemic features. B. Autoimmune hepatitis. Lupus-associated hepatitis, mimics. 1. Primary biliary cirrhosis, PBC. Both autoimmune hepatitis and PBC can present with fatigue, jaundice, and elevated liver enzymes, but PBC is associated with antimitochondrial antibodies, unlike lupus. 2. Viral hepatitis, e.g., hepatitis B or C. Viral hepatitis presents with similar liver enzyme abnormalities, but it can be distinguished by viral serologies and a history of exposure. 3. Drug-induced liver injury. Many drugs, including those used in lupus, e.g. methotrexate, azathioprine, can cause liver enzyme elevation and mimic lupus hepatitis. 4. Hematologic manifestations mimics. A. Anemia, autoimmune hemolytic anemia. Mimics. 1. Iron deficiency anemia. This is a common cause of anemia that can mimic lupus-related anemia, but is characterized by low serum iron, ferritin, and transferrin saturation. 2. Hemolytic uremic syndrome, US. This condition can cause hemolytic anemia, thrombocytopenia, and renal involvement, similar to lupus, but is often triggered by infections, e.g. E. coli. 3. Thrombotic thrombocytopenic purpura, TTP. TTP can cause anemia, thrombocytopenia, and microangiopathic hemolysis, mimicking lupus-related hematologic manifestations, but it is associated with ADAMS13 deficiency. B. Thrombocytopenia mimics 1. Immune thrombocytopenic purpura, ITP. Isolated thrombocytopenia without other systemic lupus features can mimic lupus thrombocytopenia but typically lacks autoantibodies. 2. Aplastic anemia, bone marrow suppression causing pancytopenia, may be confused with lupus-induced thrombocytopenia, but aplastic anemia involves bone marrow failure rather than peripheral destruction of platelets. 3. Drug-induced thrombocytopenia. Medications like heparin-induced thrombocytopenia, or certain antibiotics can cause thrombocytopenia, mimicking lupus-related thrombocytopenia. C. Leukopenia mimics 1. Drug-induced leukopenia. Immunosuppressants like methotrexate or azathioprine used to treat lupus can themselves cause leukopenia, which may be mistaken for lupus-induced cytopenia. 2. Viral infections. Certain viral infections, such as HIV, hepatitis, or Epstein-Barr virus, EBV, can cause leukopenia, mimicking lupus-related leukopenia. 3. Myelodysplastic syndrome, MDS. This bone marrow disorder can cause cytopenias, including leukopenia, but is usually accompanied by characteristic bone marrow findings and chromosomal abnormalities. 5. Other organ systems mimics. A. Antiphospholipid syndrome, APS, and hypercoagulability. Mimics. 1. Deep vein thrombosis, DVT, and pulmonary embolism, PE. Lupus patients with APS are at risk for DVT and PE, but these conditions can occur independently of lupus and may be triggered by other hypercoagulable states, e.g., malignancy, oral contraceptives. 2. Thrombophilia disorders, e.g., factor V Leiden. Inherited thrombophilia conditions can cause recurrent clots and mimic APS in lupus. B. Fever of unknown origin, FUO, in SLE. Mimics. 1. Infectious causes. Tuberculosis, endocarditis, or other occult infections can cause persistent fever and systemic symptoms, mimicking SLE flare-ups. 2. Malignancy, e.g. lymphoma. Lymphoma can present with fever, weight loss, and night sweats, B symptoms, mimicking SLE. Both conditions can also cause lymphadenopathy. 3. Adult onset Still's disease. This autoinflammatory condition presents with fever, rash, and arthritis, which can mimic lupus but is characterized salmon-colored rash and markedly elevated ferritin levels, which are not typical of lupus. 6. Other immune-related manifestations mimics. A. Sjogren's syndrome-like symptoms. Dry eyes and dry mouth mimics. 1. Primary Sjogren's syndrome. While lupus can involve Zika symptoms, dry eyes and mouth, primary Sjogren's is characterized by more severe glandular involvement and is often associated with anti-Rho SSA and anti-La SSB antibodies. 2. Medication side effects. Drugs like antihistamines, antidepressants, and certain antihypertensives can cause dry eyes and dry mouth, mimicking Sjogren's-like features in lupus patients. 3. Sarcoidosis. Sarcoidosis can cause dryness of the eyes and mouth, but is more commonly associated with pulmonary and lymphatic involvement. It is characterized by granulomas on biopsy, unlike lupus. B. Fatigue and malaise. Mimics. 1. Chronic fatigue syndrome. CF. Chronic fatigue can mimic the debilitating fatigue seen in lupus, but CFS is a diagnosis of exclusion and lacks the serological and systemic features of lupus. 2. Depression. Psychological factors like depression can cause profound fatigue and malaise, overlapping with lupus-related fatigue. But depression lacks the immune and inflammatory components of SLE. 3. Hypothyroidism. Hypothyroidism can cause fatigue, weight gain, and cold intolerance, mimicking some of the constitutional symptoms of lupus, but is easily identified by abnormal thyroid function tests. HAR7 mimics of constitutional symptoms in SLE. A. Weight loss and night sweats. Mimics. 1. Malignancies, e.g. lymphoma, leukemia. Lymphoma and other cancers can cause weight loss, night sweats, and fatigue, which can be mistaken for lupus flare-ups, especially in the absence of clear cutaneous or renal manifestations. 2. Infections, e.g. tuberculosis. Chronic infections such as tuberculosis or fungal infections can present with fever, night sweats, and weight loss, resembling systemic lupus symptoms. Conclusion. SLE mimics a wide range of diseases across multiple organ systems. Careful clinical evaluation, targeted laboratory testing, and imaging studies are essential for distinguishing SLE from other conditions that present with similar symptoms.